Chapter 37 is alterations of digestive functions within the children. In some cases, digestive issues in kids will be very similar in physiology to the adult. The biggest issue with the child, though, is going to be nutrition. If a child doesn't have proper nutrition for a long period of time, that can have lasting consequences, both in physical development, overall growth, and really more importantly, the neurological development. So a lot of these diseases, very similar to the adult. Some of them we have already discussed in some detail, some of them not yet. And then some of the material might be material that you've heard about either through Chapter 36 or even through just common knowledge, the media, your family even. So the first disease that we'll look at is intussusception. And we looked at this in Figure 36, or in Chapter 36. And in the adult, this was a intestinal obstruction, right? Figure 36, 4b. With the child, same thing. It's telescoping of a proximal segment of intestine into a distal segment, and this causes an obstruction. And so you can see this figure here, where this portion of the intestine is being pushed back, and as it's being pushed back, it squeezes or condenses, pinches off the opening for material to move through properly. And so then anything moving down is going to get stuck here and become obstructive. So the most common place in the child is going to be at the ileocecal junction, which is what is shown here. And the age at which this is most often seen is going to be age 5 to 7 months. Unclear exactly why that is, potentially because that's about the time where an infant moves from pure liquid diet to adding food in. But this can be a very serious issue because if it's not corrected, it can be fatal. It causes ischemia to this portion of the intestinal tract, and then that ischemia can lead to necrosis, and then that necrosis takes over. Material will eventually move out of the bowel into the peritoneal cavity, and that will lead to sepsis and death. All right, so clinical manifestations of this: abdominal pain, irritability, vomiting, current jelly-like stools. In the child, again, it's very hard to, or in the infant, it's hard to narrow down why a child might be irritable. Abdominal pain, they're not going to really show, or they're not going to talk about abdominal pain. They're just going to cry and be irritable. So evaluation and treatment, ultrasonography, and trying to force that intussusception away. It can be completed or done with an air enema, and then also, if it is bad enough, surgical reduction. Now, cystic fibrosis is a disease that is inherited. It's a fibrocystic disease, and it's going to involve the mucosal chloride and sodium ion channels in many organs. And typically, when you think about cystic fibrosis, you think about the lung issues. However, you have a lot of these, you have a mucosa lining of your GI tract, and so therefore the GI tract can be affected. And really where it's going to be affected most is in both the GI and the pancreas. So in the digestive tract, it causes blockage of the pancreatic enzymes. And what that leads to then is going to be this triad of events: obstruction, infection, and then followed by inflammation. Without those pancreatic enzymes, you have maldigestion of proteins, carbohydrates, fats, and then fat-soluble vitamins. And this is going to lead to chronic malnutrition. And that malnutrition is going to be due to maldigestion. All right, so you have the maldigestion leads to malnutrition. Celiac disease is caused by hypersensitivity to the gluten protein, right, a protein component in many cereal grains, wheat, rye, barley, malt. This is becoming more common, and just going gluten-free is a fad, not a fad, but kind of a popular thing to do with some diets, as well as really the physical need to do it because of celiac disease. So it can be due to autoimmune issues, and what ends up happening is because of that autoimmune process, there's loss of the villus epithelium, and so therefore you have a lack of absorption of the material from the food. So results in malabsorption, and then when this occurs in the infant or the young child, the toddler, then you have lack of growth. So the disease appears to be caused by dietary issues, genetic, and then immunological factors. Right? So all three of these combined will cause the disease. Onset of manifestation depends on the age of the infant when gluten-containing substances are added to the diet. So if the infant already has it, right, then they're not going to show symptoms until gluten is added, and typically then it's even going to have a period of time where they're eating gluten-containing foods but don't show disease. And then the severity of symptoms is going to vary from person to person. Celiac crisis is going to result in severe diarrhea, dehydration, malabsorption, protein loss. Again, it won't go on an excessive amount of time before medical intervention is done, and so you're probably not going to deal with a life and death situation, but that diarrhea can be quite severe. The dehydration in a toddler could be life-threatening, but generally then you can hospitalize the child and put them on IV solutions. Diagnosis is made with serological testing, looking for those autoantibodies, and then putting the patient on a gluten-free diet for the rest of their life. Now, how does celiac disease lead to malnutrition? All right, you have the gluten intolerance. That's going to start the process, and the gluten intolerance is going to develop due to T-cell activation, antibody production specifically against the gluten protein, and then complement activator. And so the initial effects is you have that villus injury. With that villus injury, you have decreased surface area within the intestinal tract that is going to allow for absorption. Because of these T-cell response and the complement activation, you have inflammatory enteritis, right? Inflammation within the intestinal tract. You have osmotic diarrhea, which leads to secretory diarrhea, just pure, almost pure liquid being drained from the individual. And in the end, you have decreased electrolytes, decreased proteins, leading to malnutrition. All right, decreased surface area within the small intestine. You have decreased carbohydrate absorption, decreased protein absorption, decreased fat absorption, leads to malnutrition. All right, secondary effects because of complement or the antibody production, mucosal damage. Decreased intestinal hormones will be produced, the different enzymes that are necessary. Decreased pancreatic function. Without the pancreatic enzymes, you have decreased carbohydrate metabolism, decreased protein metabolism, fat metabolism, which then decreases the absorption, which leads to malnutrition. All right, now failure to thrive. There's a fair amount of material that you can read here, and we won't spend a whole lot on it, but failure to thrive is what you will hear if your child is very small and just isn't progressing say from that 2-week checkup to the 1-month checkup to the 2-month to the 4-month, whatever your checkups are going, even if a child is small to begin with at birth, if they put weight on and continue to grow, then they're thriving. It's also called growth faltering, and it's characterized by inadequate physical development. All right, so this is physical development of the infant or child. So there's a deceleration in weight gain. So again, you're not moving up that growth chart. And low weight to height ratio, or BMI ratio, low weight to height to head circumference ratio. And the factors can be multifactorial. It could be biological. All right, what kind of genes do you have? What kind of genes did both parents add to the mix of that new child? It could be psychosocial. It could be environmental. And a lot of states have different places to set measures at what they considered failure to thrive. I know in Oregon, if there's a variety of different boxes to check under that failure to thrive diagnosis, so to speak. And both of my sister's kids were in this spot of failure to thrive. Both of her kids got to, 3 boxes being checked, and once you get to 5 boxes being checked in Oregon, then DHS is brought in, because failure to thrive might be an issue of the parent not giving the child food or something along those lines. It could be neglect. So there's a lot of things to look into, and a lot of times it's just the child, right? They're just not big, they're just not growing fast. The next disease is necrotizing enterocolitis. This is an ischemic, lack of blood flow, inflammatory condition that causes bowel necrosis and perforation. The perforation is very bad because, again, that leaks all of the intestinal components into the peritoneal cavity. Most common severe neonatal gastrointestinal emergency, and this is what's going to happen, say, if you had an appendix rupture. Right? That's the perforation in terms of releasing material into the peritoneal cavity. Primarily affects the very small and the premature infants. Why this develops, the etiology of it is unclear. All right, some contributing factors can be infection, abnormal bacterial colonization, intestinal ischemia, immature immunity, extra inflammatory responses, lack of intestinal motility, lack of barrier function. All right, if those intestinal cells don't sit right next to each other and have some real good tight. So if the cells are not stuck to each other tightly, with those tight barrier junctions, bacteria can get through the cell. If you imagine barrier and function here being 2 cells, bacteria can make their way between there, get down into the basement membrane and cause that inflammatory reaction to start. Medications, feeding practices, genetic predisposition can also be issues. All right, clinical manifestations, mild abdominal distension, all the way up to bowel perforation. There can be bloody stools. Because of that, inflammation where red blood cells are brought in, and then this can also lead to septicemia with bacteria moving into the blood from the gut. All right, evaluation and treatment, clinical manifestations, lab results, looking at how spread out that disease or how far that septicemia has occurred, cessation of feeding, gastric suction, antibiotics, surgery to help clear out that inflamed area.